Looks good.
All right. Does that look good?
Yeah.
Great. All right. So I am Brandon Yarnes, and I'm actually a psychiatrist in Los Angeles, and I'm an assistant professor at UCLA, University of California, Los Angeles. And I conduct most of my clinical work at VA Greater Los Angeles at the U.S. Department of Veterans Affairs. So I work mostly with U.S. military veterans. And so I'm very pleased to join you today to talk about group Eaet. So I do have these disclosures. I have a current grant funded by the U.S. Department of Veterans Affairs that I will be talking about that deals with Eaet. And I also have this disclaimer that they require me to say that I'm not representing them in this presentation or anything I say. All right, so what I'm going to talk to you today about is I understand that you have had a lot of different talks and lectures on different formats of Eaet. So I'm going to begin by discussing with you why group Eaet? Why would you want to do that? Why do I think it's important to conduct Eaet in groups and potentially very helpful? And second, I'm going to talk some about the research that Robert mentioned on group Eaet that Mark Lumley has done and that I have done as well here in Los Angeles. And then what I was hoping to do was talk to you more about the clinical provision of group Eaet. And so I have some slides where I'd like to walk you through what I think are the key elements of the group Eaet manual and try to get a flavor of how we get you inside the groups so that you can see how we actually do the groups and how I think it's very effective. And then I do have a video case example that I've prepared closer to the end. All right, so first let's talk about why we want to do Eaet in groups. So I think there is some evidence, particularly in my studies, about groups having a larger effect size than individual formats of Eaet. Like they seem to provide bigger benefits on average for the patients based on the work that I've done. And so why might that be? Is it because the groups are somehow able to be more powerful than individual formats, or do they help people that otherwise may not benefit from an individual format? And I think it's both. We could get into the numbers and try to make a claim for one or the other. Do individual patients have larger effects, or do more patients have an effect? But I think really I want to talk more about what my clinical experience is. And first of all, are more people able to benefit? So I think we have to have some humility, at least I do in my practice setting, that when we are talking about Eaet, when we're telling patients that it's really the brain and the way they deal with their emotions that is accounting for much, if not all, of their chronic pain, this is very different from what practically every other doctor has told them about their pain. So I have a list here that my coordinator have compiled of different things that veterans say that show their skepticism when they start. And the top ones at the beginning of the list are that their pain is due to medical factors. They've been told that they have a problem in their back that's causing their pain. They've been told that, oh, their pain is real, and you're saying it's in my head, even though we take pains not to ever say that it's in your head and really explain that very thoroughly. Patients still think that's what we're telling them. And so the thing about being in groups is that the patients don't have to go first. They don't have to try it, but they can have in a group a whole range of different patients with different levels of buy-in, different levels of skepticism. And somebody is going to take that first step and they're going to do the work and they're going to get the big benefit. And then the other group members can see that patient doing the work, what they did exactly, how this works, and how somebody's supposed to benefit. And I've seen over and over again that increases the other patient's motivation and interest in diving right in and participating. So I do think we're able to reach people in a group that are otherwise going to be skeptical in an individual format and just continue to remain skeptical and push back and try to basically argue with the therapist. The second thing about groups being more powerful is that I've seen that people in the groups, one person will start talking about something and other group members will think, oh yeah, that is me as well. So in our group that we did last Wednesday, one patient was talking about his stepfather and growing up and the relationship they had. And then all the other group members started jumping in and saying, oh yeah, I have a stepfather. So they really help each other by thinking of things to work on and get deeper and deeper into the material in a group. And I really think that also helps make them more powerful. So I also finally think that groups are just a lot of fun. It's great bringing together a bunch of patients who have a similar lived experience and hearing them go back and forth. They become mini experts in this therapy and how it works by the end. And you'll see them jumping in, helping each other. And it's a great process that I really enjoy. So now that I've given you my pitch, I'm going to talk about some of the research on Eaet in groups that has been done. So I'm just going to touch on one of Mark's study, his big study you've probably already heard of if you've heard from Mark, of patients with fibromyalgia that he conducted in Michigan. So it was a large study with 230 patients with fibromyalgia. And they were almost all women. It was 94% women, and over 3/4 of them were white, an average age of 49. And you see they were randomized to 8 group sessions of either Eaet, CBT, or fibromyalgia education, which was a control group. And you may have seen these results already. This is the number of patients with substantial, at least 50% pain reduction by the end. And the black bars on the left represent Eaet, on the left at post-treatment, and then on the right at 6-month follow-up. And you see that the Eaet groups had a lot more patients achieving a large, at least 50% effect on their pain compared to the other two groups. And it was a statistically significant difference between favoring Eaet over CBT at 6-month follow-up. And then one more little graph on his study showing the number of patients who no longer met criteria for fibromyalgia by the end of the study. It was much larger in the Eaet group. Nearly 30% of the patients didn't even have fibromyalgia again after completing Eaet. And it was statistically significantly different for over CBT and education control at 6-month follow-up. And you can see it's just another interesting thing here. If you look at the black bars, focus in on those, that at the 6-month follow-up, actually more patients met these criteria than at post-treatment. So it seems like not only do they potentially benefit more from Eaet during the treatment, but they just continue to get better and better after the treatment. And that's what we've also observed. So this study, like I mentioned, was people who were not military veterans. They were mostly women. They were mostly white. They were younger, as far as I'm concerned, as an old age psychiatrist. And so I wanted to do something totally different here in Los Angeles, which was to take military veterans who are mostly men. And I wanted to take an older population of our US military veterans. And I wanted to broaden it out, not just to test fibromyalgia, but to look at a wide range of musculoskeletal conditions that we think have a greater involvement of the brain and emotions. So we accepted patients with chronic back pain, chronic neck pain, fibromyalgia, whiplash, tension headaches, and we really only excluded patients with serious mental illness or severe substance use disorders or cognitive impairment. And so we did randomize these people, as Robert said, to either Eaet or CBT. And we did the 8-session group manual, but we also added an individual session with each patient prior to the start of the group, just to get to know each patient on an individual level, hear their story, and begin to see where they are in terms of skepticism, how much we think stress and emotions relate to their specific pain. And we collected patient-centered outcomes, pain severity, pain interference, mood and anxiety, sleep, fatigue, and life satisfaction at baseline, post-treatment, and 3-month follow-up. So you see here that we did have an older veteran population. The average age in this study was 73.5 years, and we had, whereas Mark's study had 94% women, we had about 93% men in our study, and it was a racially, ethnically diverse population with greater than 50% of the participants being non-white. It was a small study. We did 4 Eaet groups and 4 CBT groups in this study. So there were 28 Eaet completers and 25 CBT completers. So as Robert mentioned, in this study, we did show large, statistically significant advantages of Eaet over CBT at both post-treatment and 3-month follow-up. So if you follow the red line, that's the Eaet pain scores. They started at about a 6 on a 0 to 10 scale. They went down to about 4, 4.5, and they, like the other study, continued to get better. The pain went down on average a little more at the 3-month follow-up, whereas CBT, the blue line, they went down a little bit on their pain, and then it went right back up to where it started, which is what we see right in every study of CBT practically, that the effects don't really last beyond post-treatment. They go right back to where they were at the beginning if you look at any follow-up period. This second picture here is showing individual improvement. So the dots are where they started on their pain score, and then the end of the arrows are where they ended their post-treatment pain score. So the length of the arrow is how much an individual patient improved. So a bigger arrow means more improvement. And you can see there are a lot more long arrows, big arrows in the Eaet group than the CBT group. And so in total in this study, about half, almost half of the Eaet patients had clinically significant pain reduction. And there was really only one CBT patient who had clinically significant or at least 30% pain reduction. So after this study, we wanted to replicate it in a larger sample. And I got that VA grant that I mentioned to do 10 Eaet and CBT groups in about 160 veterans. I got that grant in 2019, and then everybody knows what happened. We were conducting group therapy with older adults. It was like the highest risk thing we could possibly do. So the study was put on hold for over a year. Actually, we couldn't do any groups due to COVID-19 and the research restrictions. So everybody was telling me, well, just go ahead and do the groups online, do the groups over Zoom like this, have the patients join. And I said, well, we've got older patients. I don't know how well they're going to do with technology. And also, there's only one study that I was aware of at the time that tested any kind of emotion-focused therapy. It was an intensive short-term dynamic psychotherapy, or ISTDP study. You may have heard of this in the nation of Iran. The first author was Chavushi, and he compared in-person and telehealth ISTDP for chronic pain and found that it didn't work over video telehealth. And so I was very concerned about just moving my study over to telehealth. So I said, but I'm willing to try it but it's a different study. So I got separate funding from the U.S. Department of Veterans Affairs to do some groups of EAET online over Zoom. So we took our older veteran population and we actually gave them all a tablet, since we had the grant funding to do that. And I had a research coordinator call them, and they helped them over the phone to connect the tablet to internet and to try to get on Zoom, and also to get onto an online platform to complete questionnaires. And we made this technology training manual that we sent out to all the veterans that showed them how to use the tablet, how to connect it to Wi-Fi, how to join Zoom. It was all written out in big type so that the veterans who were older could read it. So then everybody in this study completed 9 EAET sessions, the 1 individual session and the 8 group sessions, and they did online assessments at baseline, post-treatment, and at 2-month follow-up. So this study, we did 3 groups, and they were all EAET groups. There was no CBT comparison, but it was an older, average age 72 years, again, mostly men. This one was about 80% men and mostly non-white participants. And so these are all the outcomes we collected. I have the effect sizes here for the outcomes. You're probably familiar with effect sizes by this point. A small effect size is 0.2, medium is 0.5, large is 0.8. And so you see on pain reduction, which is at the top in the black, that we had a very large improvement in reduction in pain, an effect size of -1.5, which is at post-treatment, and it was largely maintained into follow-up, -1.2. So the other outcomes, mood, anxiety, also had medium to large effect sizes. And in this pilot study, which I'll admit we had pretty special patients, we took patients who had been very good participants who had attended all the sessions in CBT previously in my studies, and asked them if they wanted to do EAET. So we knew they were good, reliable patients. We had no dropouts on these 3 online groups. We had great attendance. They attended on average 7 to 8 of the sessions. And so we had over 80% of them show clinically significant improvement. And we had 3 of the 16 have 90 to 100% improvement in this pilot study. So contrary to the previous studies, we found that you can do EAET online in a video telehealth format. Now, this was all, as I said, over Zoom. It wasn't the online version that Robert and Daniel Marodi have put together. This was actually live groups over Zoom. And I think it was a risky thing to do, but it looks like it was highly effective. And could it have been the groups? Could that be the difference between the findings of Chavushi in 2017 doing online ISTDP that didn't seem to work versus ours being a group? We don't know. So what is the research next steps? So we have resumed the large study, which we're keeping in person, that compares EAET and CBT with 160 veterans. It should be complete next year sometime. And then I put in a grant to study EAET in a group format specifically over Zoom and compare it to CBT and mindfulness. So that grant is under review. And we also have an fMRI grant that we have submitted that hopefully we'll actually be able to see the brain changes that we think are accounting for the improvement in EAET. But that's still in the works. So that was a very quick rundown of the research that I've done, a little bit of Mark's research. So I would like to move on now for the next few minutes to discuss the clinical provision of EAET in a group format. So everybody is familiar, just as a reminder, by this point in the training, you know the EAET conceptual model, and that is that stress in your life, it can be daily hassles, conflicts in relationships, more difficult things like trauma. There have been evidence of things like secrets and private conflicts and issues, all sorts of stress. It all creates in a person emotions, makes them feel a certain way. And those emotions can be difficult for people. And so what happens is your outcome depends on what you do with those emotions. So if you tend to avoid your emotions, suppress them, push them down, not talk about it, then we think that is what is responsible for pain, other symptoms, maybe related symptoms, other physical symptoms like irritable bowel syndrome, mood symptoms, depression, anxiety, sometimes PTSD. Whereas if you face your emotions, experience and express them, then that is associated with reduction in pain and symptoms and normalization of brain changes. And that's really what Eaet helps to facilitate, is taking patients who have avoided emotions about the difficult relationships and traumas that they've had in their lives and help them to face all those feelings. We think it's associated with brain changes that can modify chronic pain and other symptoms. So the group protocol that we use in all of our studies is this manual developed by Lumley and Schubner. Now, I don't know if you all have this manual, if it's been distributed to the group. If not, I'm sure Mark would be happy to give it to you, or I would be happy to send it along. Mark said I could send it to any interested clinicians. So the original manual was developed for his fibromyalgia study. And it's since been adapted by Mark and myself for other chronic pain conditions, and of course, adapted for other somatic symptoms, online format, I think, that Robert and Daniel did. And so this is a picture, of course, of Mark Lumley and Howard Schubner, who you've heard from before and who developed the manual. So I'm going to talk generally about the manual and then walk you through what I do actually in each session. One thing about the manual is that it's incredibly detailed. There's a huge number of different exercises that you can do during the sessions and a large number of homework assignments. I think the handouts, the homework assignments that Mark distributes to therapists have 141 pages of exercises. And certainly they're all wonderful. But our veterans who are older, they don't really engage very well with doing all of that paperwork. So what I have taken is like what I think are the key homework assignments, and that's what I give to the veterans each week. And I'd like to tell you what I do. And I'm happy to share these slides as well. You're probably not going to remember all of this afterwards. But the overview is that we do precede the group by an individual session, really just getting to know the patient, their history, what kinds of things they have been struggling with, how long, and what they think about the idea that stress and emotions may be affecting their pain. And so then each of the 8 group sessions is designed to be 90 minutes. I think if you did a group session for 2 hours, it would be just fine, because the veterans in our group, they usually want to go on and on past the 90 minutes. We try to have to stop them each week. So we at least start and end the session with a pain score, and we very carefully monitor their pain score as they're doing the exercises. So we ask, right now, what is your pain on a 0 to 10 scale? Starts at an 8. When you do this, does it go to a 7? When you do this, it goes to a 9. We're very much keeping track of that to try to help them build that personal understanding of how their emotions affect their pain. And so a couple more observations here is that a lot of it, Mark says, is individual therapy in a group format. So many of the exercises involve going around to each of the patients in the group and having them work on their own stress and emotions with the other group members mostly observing. Maybe they'll have a comment, maybe they'll jump in with something. But it's very important to try to make sure that the group is engaged and paying attention. And most of the time they are. So if somebody is really doing some deep work about trauma, about something very painful in their life, then most of the patients are very attentive. My coordinator says it's really like watching a good movie. I mean, to hear these stories that they have. But we do try to make sure that everybody's following along so that we can increase the motivation and the effort of every group member while individuals are doing their work. And finally, I'm going to present, like I said, the rough outline of what we do for each of the 8 sessions, but I think it's important that we're flexible with the manual. And if a patient starts talking about something that maybe in session 5, when we're in session 3, I think it's very important for the therapist to have a firm grip on the manual and be able to pivot and take up what the patient's saying. If we try to be attentive to where the patient is at that particular moment and try to be with them in the moment. So each of the 8 sessions is made up of 3 components as I understand it. And so there's some psychoeducation, and here are some examples, kind of a lesson, what I call a theme for each session that we discuss. And the second part is an experiential exercise. And so that is the meat of Eaet, that we ask them to do these emotional experiencing and expressing exercises. And there are some examples there. And then, like I said, each has homework. We make homework optional, but encouraged. We want the patient to do the homework so that they're thinking about these ideas and doing some work in between the sessions. And we often ask the patient to say, oh, well, what about your homework? What have you done? What have you thought about? What would you like to bring in today that you learned from doing the homework assignment? So it's also a good way, the homework, of tracking how much a patient is actually participating. If they did the homework assignment, then we know that that's a patient that's really working hard. And so we do address it if patients are not doing the homework assignment. So even though we officially make it optional. All right, so group session 1. The psychoeducation is really the overview of stress, emotions, pain, and brain changes. So I do this very quickly in the group. I make 4 points. The first thing is everybody knows that you feel pain in your body, right? And it's real. And if your back is hurting, you're feeling it in your back. And that is a legitimate thing. But what you may not know is that pain is also in your brain. And it is actually the brain which determines whether or not you're feeling pain and how much pain you are in. And so the brain is really the organ of pain. The second point is everybody knows feelings are in your mind, they come from your brain, but feelings are also in your body. Emotions are in your body. And so there's a great exercise in the manual that asks patients, do you know this already? What kinds of physical reactions to emotions do you already know about? And people say things like, well, I sweat when I get nervous. If I'm embarrassed, I turn red in the face. So people are aware of emotions being in the body. So we teach them that every one of your emotions has an effect on your body. Or if it doesn't, it should. And we're going to be teaching you what emotions feel like in your body. So how we tie these together is that avoided feelings, like I just discussed in the model, we teach this to the patients, they actually produce changes in those same brain regions where both pain and emotion are determined. And that is what is actually causing most, or in some cases, all of your pain. And so by facing your feelings, which is what we're going to do in this group, we can actually change those brain regions and get you to reduce your pain and get you feeling other ways in your body. So that many pain patients, when they come in, however they feel, what they're feeling in their body is just pain. So if they get stressed, if they get anxious, if they get angry, if they get sad, they just feel pain. And we're literally trying to change your brain, which will enable you to feel literally differently in your body, to feel anger when you're angry, to feel sad when you're sad, and to feel happy when you're happy. And so that is the way the therapy works. So we present that conceptual model again, like 3-4 minutes in the group, in the first group session. And then because we know each of the patients, we've had an individual session, but they don't know each other. We have them introduce themselves, and in the manual, there's this great exercise which asks the patient to introduce yourself and say something that you are personally proud of. This is the actual text. I don't know if you can read it there, but it says, tell something you're personally proud of, not about your family or your kids, but about yourself. This is just so good at revealing the defenses, getting familiar with the patient. And oftentimes patients will say, I can't think of anything. I don't have anything I'm proud of. And so you begin to see their relationship with their emotions. And it's a good opportunity to start with positive emotions and make the point that, hey, some of us have trouble with positive emotions, like we have trouble feeling good about ourselves. And feeling good is tied to a bunch of negative emotions. Waiting, we have this expression, waiting for the other shoe to drop, expecting a bad outcome, expecting negative emotions to come and pain to come. And so we're really able to make that point about the relationship between emotions and pain through this exercise. So it's really good. And frankly, we spend most of the first session on this exercise, having each patient go around and discuss something they're proud of, and how that feels physically when they say something they're proud of, and how it relates to their pain. And then for homework, there's this stress symptoms connection exercise. Now, the manual says to do it in the session. I found if you try to do it in the session, it takes the whole session. So I usually assign it for homework. And so it's 4 pages. There's a list of symptoms that asks the patient, when did your chronic pain start? If you have stomach problems, when did that start? If you have depression, anxiety, PTSD, when did that start? The second step is to list stressors that they've had in their lives. So you have adverse childhood experiences. Is there a time when you were abused, neglected, in your adulthood, sexually assaulted, your military service, stressful life events? The third part is about, it calls it core issues. These are psychological things that the patients think that they have problems with. You have problems with closeness, you have problems with having resentments, never feeling loved. And then the fourth page really tries to put it all together and make a timeline of, when did they have major stressful life events? Does that coincide with when their symptoms started? And are there core issues or psychological issues involved, particularly around avoided emotions, closeness or anger or grief that they didn't fully process? Again, the goal of this is to try to get them to increase their motivation and want to learn personally for them that stress and emotions, life events are related to their chronic pain. So in the second session, we present the triangle model. Now, is everybody familiar with the triangle of conflict, triangle model? Yes. Yes, okay. So I'll tell you, because part of what I'm wanting to do, and like I said, I'm happy to give you these slides, is talk about the way that we teach it. And we simplify it from what is in the manual. And really, the triangle of conflict or the triangle model comes from Freud's second theory of anxiety, which is that anxiety is a signal that dangerous or conflictual feelings are getting activated, and that anxiety is inherently unpleasant. And so you don't want to stay there. So defenses are put into operation to lower that anxiety and get rid of the feelings. So in the manual, I think there's a discussion about primary and secondary emotions, and there's discussions about inhibiting symptoms. And I think the three corners of the triangle are a little bit confused, if I may say so. So we give the patients this simplified version of the triangle. This is in the handouts, and I included on the slide the lines so that they can write what are the defenses that they use, how do they experience anxiety, what kind of feelings do they have trouble with, and they can track it for themselves, which I think is a really empowering thing. And so what we say to the patients is that feelings are normal, natural, you're born with them, they are tied to important needs that you have, they give you important information about your needs, what you want, what's important to you. However, in childhood, in growing up, many of us learn that certain feelings may not be safe. Like if you get angry at your father, he punishes you. He says, don't you be angry at me. Maybe feelings of closeness, love, like you didn't have the kind of mother that would hug you, that would bring you in and say, hey, baby, what's going on? I love you. And so we learn certain feelings are dangerous, off limits. So when they come up, we get scared of them. That is the anxiety corner of the triangle. Because feeling scared is very unpleasant. Nobody likes feeling anxious. We use defenses, which are all sorts of ways of avoiding talking about feelings to bury the feelings and lower our anxiety. That's the way we present it to the patients. And we give examples of defenses. There's actually a checklist of defenses that you focus on what happened instead of focusing on your feelings. There are all sorts of defenses that are explained in plain English, and we do give that to the patients to really think about. So that's the theme for the second section, is really identifying your triangle. And the experiential exercise is experiencing anger and closeness. So how do you know that you're feeling your feelings? That's a big thing in this therapy, right? So we give a very specific way, which is really derived from ISTDP that I mentioned earlier, that we experience a feeling in words. If you're angry, we are able to put that into words. I'm mad, I'm angry, I'm pissed off. We feel the feeling, as I mentioned earlier, in our body. And when we're discussing anger, that is a very important thing to discuss, because almost every pain patient that I've ever seen, they come in and they say, oh, anger. Oh, I feel very tense. I feel it makes me feel terrible. And so we think, well, what does healthy anger feel like? That it's strong, powerful, energetic, you feel grounded, you feel energy, you feel powerful. We say, when is the time in your life when you have felt pure anger, no fear, no anxiety? And they're usually able to recall at least one example of that. And so really trying to help them understand what feelings are supposed to feel like, that they feel energetic and good, and not just feel anxious about them. And then we teach that feelings are part of the experience of feeling is what the feeling makes you want to do. That's why we have them. They're tied to our important needs. So with anger, sometimes you want to haul off and hit somebody or yell at somebody, but healthy anger helps us to want to set boundaries with people, say no, be firm, assert ourselves to get our needs met. And then we also discuss what emotional closeness, love feels like. what words you can use, how it feels in the body, soft, warm, and what it makes you want to do. Go up and hug somebody, be close to somebody. And that's how we start showing those two sides of the feelings and with these exercises. And often here patients do bring in things from their lives, examples of when they got angry or examples of when they had difficulty with closeness. And we work with that as best we can here, even though that's really beginning the experiencing, expressing, and releasing from session 3, which I'll talk about more in a moment. So the homework assignment for session 2 is investigating your childhood. And this is a really important homework assignment. It asks about growing up, adverse life experiences, your relationship with your mom, your relationship with your dad. It usually, we hope, stimulates a lot of thought with the patients about their childhood and gets them to identify some stressful experiences from their life that they can bring in and talk about and work through all their feelings about in the upcoming sessions, which is really the aim of all the homework assignments. So it's about 7:15 where I am. Should we take a little break for a moment?
Yeah, how about
break up
having a 5-minute stretch?
Okay.
5-minute short break. Yeah, we have a short question before.
Absolutely. Yeah, I'm happy to have any questions.
Can you hear me?
Yes, shout it out.
Yeah, I'm curious as to the, I don't know what to call it, but do they do their homeworks? Simply put, is that your experience? Because I find it, if I look at how you sketch them for us, they look extremely ambitious. I'm used to working with home assignments because I come from the behavioral corner, but just a comment would be really.
So are you asking, do they do the homework?
Yeah.
Yes. Okay. So I'll tell you, usually they don't at the beginning. All right. Yeah, they tend not to do it. And the more that they begin to understand the therapy and the more that they have the benefits and see the benefits in others in the sessions, then the more likely they are to do the homework afterwards. And so I see over and over again, like this current group we're running, nobody did any homework for the first 3 weeks. They were still thinking about it, not really believing it. And then suddenly in session 3, where people really started getting into the emotions, they really started getting it, then they start going back and doing the homework.
Oh, really?
And so
capturing the old ones even.
What's that?
So even going back and doing the home assignments from the first sessions? Like,
yes, and I tell them that the homework is for you. And so you can do it anytime and any session, it doesn't matter. But I do tend to tell them like this one or that one is like very, very important. Like the session 3 homework is that I'll discuss in a moment is one of the most important ones. And so as they do motivation, as their motivation increases, I think they're more likely to do it. And it's a good marker for the therapist to see how motivated and engaged the patients are.
Thank you very much.
Thank you.
Thank you. Okay, so let's just have 5 minutes of break then, Brannon. Thanks.
Okay, sounds good.
Yep. Okay, we're back, Brandon.
All right, great.
Yeah, please go ahead.
Okay. All right, so we left off on group session 3, and that's where I mentioned things really get going in the group. So the education in this session is on conflicted feelings in relationships. So anytime you have a close relationship with somebody, it's gonna bring up a lot of feelings. And so it's important for you to be aware, experience, and be able to express empowering feelings like anger, which help you, as I mentioned, to say no to somebody, to set boundaries, to assert yourself, but also to be in touch with connecting feelings. So love, healthy guilt if you've done something wrong, to be able to connect with the person, and sadness or grief, which is really the telling you that you need a connection, that you need somebody to come and comfort you. So we teach that on the bottom of the triangle, there are these 2 types of feelings. And in the groups, we really want to experience, express, and release all of those difficult feelings that if we don't face, build up and build up and build up inside of us and can result in pain. So experiencing, expressing, and releasing is really the core of Eaet. As I mentioned, oftentimes it sort of happens in earlier sessions because people will bring in things from their lives that they want to discuss. And so the therapist just kind of jumps in to the experiencing, expressing, and releasing whenever the patient brings up a specific stressful experience. But the way it's formally done is we ask the patient to bring in a specific example of a stressful experience with another person. It can be something in their current life, like the patient said, my son, he won't ever take out the trash or do anything. He's an adult, he lives with me, but he doesn't contribute. So then we look at experiencing all of the anger that you have in the safe context of the group. I would say, yeah, my son, I get angry at him. I feel that. We want them to feel it in the group, feel that anger, and then imagine in your imagination, releasing it in fantasy, all of that at your son in your imagination in the group. So that way the anger is out of you here in the safe environment where nobody gets hurt. It's just words, it's just your imagination. And then you won't be carrying that anger and resentment home when you interact with your son and you're better able to connect with him. You just have not all the years of resentment from the past, but you just get irritated with him appropriately. It helps you assert yourself and you have all that room now to connect with him as well. So then after they get the anger out, then we ask them how they feel afterwards. And they sometimes feel satisfied, like, yeah, I finally feel like I got in touch with this power to stand up to him. And sometimes if it's a close relationship, like in my example with a patient's son, they feel guilty, they feel sad, they want to apologize, they want to go and give their son a hug, connect with him again. And we really try to get both sides of that in these conflicted feelings and relationships. And then the last part is the talking to 3 important people, as the manual says, that you talk to yourself in the past and say, you're okay, you didn't do anything wrong. You talk to the other person and say, I'm letting this anger go, I'm letting you go, or I forgive you. And then you talk to yourself now. It's like, what have you learned from this and how are you going to move forward, move past the resentment that you've been holding on to, the anger you've been holding on to, and let it go and take care of yourself from now on. So this is really the core. And we ask them to bring in multiple stressful experiences. They bring in things from childhood, they bring in things from their military service, and they bring in things from current relationships. And that's really the core of it, working through all their difficult and conflicted feelings. Then the homework assignment is the unsent letters. And I do tell them that this is one of the most important homework assignments. So whereas we're releasing all of the feelings that they have bound up from the past in the group, they can also do it themselves on paper. So they can write a letter where they release all of their anger and they release all of their resentment and everything on paper, but they don't have to send it to the person. It's a process for themselves to work out their feelings and face up to them. And so I at this point, I really start emphasizing the homework. So session 4, from here on out, we continue the experiencing, expressing, and releasing exercise, but each session, in my view, has a particular theme. It's not exactly as the manual prescribes it, but I think about session 4 as covering healthy guilt and unhealthy guilt. And so healthy guilt is when you actually did something wrong, either accidentally or intentionally. You hurt somebody because you're angry in the moment and you did something destructive. And in the case of healthy guilt, you want to confess, apologize for what you did, and try to repair the relationship. Whereas unhealthy guilt is when you didn't do anything wrong, when you asserted yourself appropriately, when you said something, and the other person is trying to guilt you. And the way you stand up to unhealthy guilt is to get in touch with your anger toward the other person who's guilting you, and love and compassion for yourself. And so we present that as the theme, and they may bring in times when they were guilted or times when they did something wrong and they felt guilty. And then we have them face all of the feelings with the experiencing, expressing, and releasing. And the homework for this week is about childhood stressors. So whereas the unsent letters can be about any stressful relationship, the childhood stressors are writing about a stressful experience that they had as a child, turning it into a narrative, trying to search for growth and meaning in the experience, and then writing to yourself as a child. How would you, in your imagination, if you were to go back, comfort that child, be there for them? And we do a lot of that experientially in the group as well, if people bring in stressful experiences from their childhood to the group. So group session 5 is, I think, a continuation of the guilt, and then we talk about shame, which is taught as sense of being defective or inadequate or wrong or bad person that is always inappropriate, and you respond to it in the same way as you do the unhealthy guilt, by getting in touch with the healthy anger and also the connection, love, and compassion for yourself. We continue experiencing, expressing, and releasing in session 5. And the homework assignment is about stress from secrets, holding on to private experiences and secrets, which we teach is a major source of stress. Session 6 is about secrets. So the homework, if they do it for session 5, tease them up. So the way we present session 6 is that you have all discussed many things that you've shared with us that you maybe haven't shared with anybody else. But if there's something else that you're holding on to, something painful from your life that you want to talk about, we're getting to the last few sessions. Now is your opportunity to share it. And the homework assignment then is about shifting to healthy communication, which is the topic of session 7. So in session 7, we say, okay, in the group and on paper with the unsent letters, you've gotten out some really powerful feelings about relationships that maybe you've held on to your whole life. You've said that you've had fantasies and maybe want to beat somebody up, yell at somebody, sometimes even kill people. That's what they share about their traumas in the group. But of course, in your relationships, you wouldn't actually say those things. You wouldn't actually say, I want to kill you, or I want to punch you in your relationship, or do it. We never want them to act on their feelings in that destructive way. But we teach it's important for you to be aware of how you're feeling, and then to communicate those feelings in a good, well-regulated way. So again, tying back to this notion of empowering or protecting and then connecting feelings, we teach the spectrum of healthy communication, which is in the manual. Connecting communications are important to maintain the relationship and closeness and express love and intimacy, while it is important to convey protecting emotions, communications as well, to assert yourself, to say no, decline, disagree with someone else, and if necessary, to even sever relationships that are unhealthy. And so in the session, the experiential exercise finally shifts from experiencing, expressing, and releasing to healthy communications if there's time. I always note that sometimes the patients still have more experiencing, expressing, releasing difficult emotions that they want to get off their chest that they've been holding on to. And so sometimes it still comes across as more experiencing, expressing, and releasing, but the manual outlines that you should try to practice a conversation that you'd actually want to have with somebody in your life and how you would communicate both sides. The thing you need to assert yourself about in that relationship, and then communications to maintain the connection and the love. And then the homework assignment that I use for session 7 is about writing your life story in a new way, starting to wrap up. So they first write, it's a 4 session writing assignment. They write their old story about how they were in pain and they were traumatized and they were stressed and overwhelmed. Then they write barriers to overcoming all of those things. And then they write the new you responds, how they would now rewrite their story as being empowering, how they would be in touch with their feelings, and how they can move forward in a happier, healthier, and less painful way. And then finally, in the last session, we do review and planning. So we have the patients talk about what they've learned, what they still need to work on by writing more unsent letters or doing more exercises or having difficult conversations in relationships. What do they still need to work on after the therapy is over? And then we ask them about their feelings about the therapy ending. And you get a lot of positive feelings. So there is sadness about the group ending, and there's sadness about, there's sometimes anger about the group ending, but really overwhelmingly, it's gratitude, it's positivity. People say at the end of this that it's changed their life. Like the patient I'm about to show, it changed their marriage. And then there is homework for the last session, creating the new you, which is related to that life story exercise before. So those are the 8 sessions. Very quickly, like I said, I'm going to send along the manual and these slides. And I'm happy, again, if anybody has any questions about how we implement the groups, then please feel free to reach out to me. I'm happy to talk with any of you if you're interested in setting up a group. All right, so I'm